Hello, everyone. My name is Corey Thornton. I am the General Manager with the Open Minds Market Intelligence team. I would like to welcome you to today's Circle Elite Executive Roundtable, Certified Community Behavioral Health Clinics, the Oaks Integrated Care Case Study. Today's roundtable features two members of the Oaks Integrated Care team, Michael D'Amico, Vice President, and Kacey Batushansky, Assistant Vice President. Before we get started, I have three housekeeping reminders. First, your audio will be muted during today's briefing. Second, we do encourage you to submit any questions you may have using the chat box located on the right side of your screen. We will present audience questions at the end of the presentation. Third, the slides and recording from today's briefing will be available on the Open Minds website in the next couple of days. With that, here's Michael to start us off.
Thanks so much, Corey. And thank you to Open Minds for having Kacey and I here today, representing Oaks Integrated Care based out of New Jersey. We're happy today to be here to talk a little bit about our journey as an integrated care provider, as well as a CCBHC provider. We're going to talk a little bit about what that journey was like for us and how being a CCBHC provider has helped us to build ourselves in being an integrated care provider that is able to provide this integrated system of care to many different populations of people and scale it throughout our entire organization, which as Kacey will talk about in a second, covers a very large area of New Jersey. So with that, I'll turn it over to my colleague, Kacey Batushansky, and she'll lead us through the first few slides.
Thank you so much. Want to click over one more? Perfect. All right, so a little about our organization first to really set the stage for our discussion. Oaks Integrated Care is a private nonprofit organization, really proud to be dedicated in improving the quality of life for children, adults, and families living in our communities. Our mission is to empower and support individuals and families to achieve emotional and physical wellness by providing quality health and social services. I know it's the reason that you're all here today. Oaks was founded 55 years ago by a compassionate group of volunteers who decided to bring their dream of a nonprofit to life. We're now a merger of 4 different organizations between the years of 2011 and 2021. Today, more than 2,400 employees make an impact in the lives of 34,000 people a year. With that, we offer now 230 health and social service programs in 19 of the 26 counties throughout New Jersey for children, adults, and families living with mental illness, developmental disabilities, addiction, and co-occurring needs. These services range from ambulatory outpatient treatment to acute care and screening services to residential care to our core community-based services. Mike, you want to hop over one? Thank you. As a large agency, our strategic planning has not been a once and done. Oaks has made ongoing strategic planning a routine initiative in growing and developing these services to meet our community's needs. The most drastic change in that plan occurred in 2014 when Oaks made the decision to shift delivery of client services to be more individualized, to be more holistic, and work towards implementation of integrated systems of care beyond just that individual's behavioral health needs. The first integrated system developed at our agency was called the Behavioral Health Home. This program was very innovative in its integration of behavioral and physical health, using nursing level staff to provide care management. Then in 2017, Oaks was selected as a provider within the original SAMHSA CCBHC demonstration project. This date really marked a new chapter in Oaks history. While we have been implementing integrated care on a smaller scale up until that point, the clinic model radically changed all aspects of the way we do business and helped to really solidify our footing in the new framework and landscape that we're now in within behavioral health. Based on what the CCBHC does, we began and really continue to adjust our service delivery, which we'll get into more as the presentation goes on. Another time, thank you. So kind of first to set the stage, what is the Certified Community Behavioral Health Clinic, which we call the CCBHC or the clinic, many different names. So with an initial investment of $1.1 billion, CCBHC represents the largest federal investment in community-based mental health services in generations. There are several aspects of the CCBHC that we feel set it apart from the traditional office or community-based siloed healthcare system that many of us have been a part of. So the first way is in concept and ideology. So the goal of the CCBHC is really to improve overall health and wellness by expanding and improving community mental health and substance use disorder treatment. Again, this is the goal of all of our agencies right now, but the clinic model provides resources and expands how we do it. So first, it increases clients' access to care. When is a client going to be scheduled for their first intake assessment? When is their psychiatric evaluation? When will they receive their first treatment service? The clinic also provides additional supports to truly integrate behavioral health, physical health, social determinants of health, which is key, and community supports. We see it as the CCBHC gives you sort of more puzzle pieces and allows us to serve even more aspects of the whole person in that whole person approach. The key is to reduce silos by working within and outside of your agency as part of a multidisciplinary team. There's more on that later. And lastly, but most importantly, in terms of sustainability, the clinic provides a novel model of reimbursement for providers to be able to flourish. That is going to be a portion of Mike's presentation today. The second aspect that sets the CCBHC apart is our continuum. So through a diverse team of staff, the CCBHC is able to provide a wider array of services to address all facets of an individual health. This expands beyond what normal office-based or even normal community-based services provide. This service array can include screening, assessment, and diagnosis, psychiatric care, and medication-assisted treatments, which we consider the gold standard of harm reduction for our addictions population, ambulatory detox services, person-centered treatment planning, psychiatric evaluation, which we have embedded in our mental health partial care programs and care management, peer supports. This to me has been one of the most exciting parts of our workforce development over the last 5 years or so. We now employ those with lived experience that are an embodiment of hope for our clients. Services also include crisis screening and response, targeted case management. This has expanded with the CCBHC model and can be inclusive of nursing care management. And within the last 2 years, we've brought structure to having patient navigators actually embedded in our local emergency departments to improve transitions of that very vulnerable population back into the community. The next aspect that sets it apart is integrated care. As with the first 2 points that I've already gone over, the goal of the clinic is integration. And I want to reiterate that the importance of this, it's occurring within your agency as well as externally with providers. Goals and outcomes for the clinic are framed around overall health and wellness across all 8 dimensions of wellness. So this is physical, intellectual, emotional, social, spiritual, vocational, financial, and environmental, right? So that is all of the aspects of wellness beyond solely our behavioral health. Next is evidence-based practices. This is, of course, not a novel concept to us as providers, but the clinic has very specific evidence-based practices that they require as part of implementation of your clinic. So this could be trauma-informed care, medication-assisted treatments, and IMR, which is your illness management and recovery. Next, more standardized outcomes. The clinic uses the healthcare effectiveness data and information set, or the HEDIS measures. This is a set of performance measures that are nationally across multiple healthcare settings to ensure consistent quality measures and standards. These can be benchmarked nationally across provider types to demonstrate effectiveness of the care model, while also allowing for value-based repayment, or VBR, to incentivize providers to achieve positive outcomes of care. Again, more on this during Mike's portion of the presentation. And finally, community partnerships sets the CCBHC apart. While CCBHC provides a broad array of services internally, there is flexibility with the model to allow services to be delivered through partner agreements. Say you don't have a crisis screening program at your agency. You can develop an affiliation with a regional agency to provide this component of the clinic. Or you don't have the capacity to offer primary care and management. Partner with a local PCP or a federally qualified health center, the FQHC, in order to implement that part of the clinic. As such, we see this model as sort of like a hub and spoke concept. CCBHC is at the center of the care, and we coordinate and collaborate with other providers, such as specialty providers, methadone clinics, self-help centers, etc. Mike?
Yeah, so just going to explain a little bit about the differences between the demonstration project and the expansion grant. So as we talk today, you're going to hear us talk about a demonstration project versus an expansion grant. So I wanted to make sure we just went over briefly some of the nuts and bolts of what those are in relation to one another. And then I'm going to turn it back over to Kacey for another couple to talk a bit more about OAKS's implementation. So for those who are aware of what the CCBHC is, or those who are intimately aware of it with what it is, there is still yet a difference between the original demonstration project that began in 2017 and then the subsequent expansion grants that SAMHSA had put out for RFP beginning back in 2018 and continuing through now. So the first, we'll go over some of the similarities. So between the demonstration and expansion grant, so both of them share the same certification criteria, which has actually recently been updated and is in draft form. We're just waiting for SAMHSA's final approval. They both include the same service array, ideology, philosophies of care, so on and so forth. So the core concept and framework is there between both the expansion grant and the demonstration projects. The expansion grants, however, are a means to an end. While they allowed organizations to stand up the model, the goal of expansion really is for the providers to find sustainability, whether that means within federal Medicaid demonstration expansion, or if that means some state-based state plan amendments or 1115 Medicaid waivers to continue the project. So essentially, we see these expansion grants as being a means to a more sustainable end. Because some of the aspects of the model are different, it does cause some inconsistency from state to state and provider to provider. The cert criteria is the same, but the models in some ways are different. The fact that one is billable and the other is grant-based obviously affects the way some services are implemented and so on. Additionally, because states are not involved with the implementation of expansion grants, this can also add to the inconsistent implementation. For the demonstration projects, the states are the lead entity with SAMHSA, and as such, they are the entity that's responsible for actually certifying the community behavioral health clinics. On the expansion grant side, grantees work directly with SAMHSA, and in many cases, states are not involved or in that equation between states and between providers. Despite the differences, the expansion grants are essential for growth of the model and integrated care in general among behavioral health. Recent legislation not just promises, but has actually signed into law the expansion of new Medicaid demonstration states and sites. And this is due in large part to the success of the initial demonstration project, as well as the potential displayed by the expansion grant projects that have allowed the model to scale nationwide. The expansion grants have been essential for organizations to prepare for Medicaid demo projects and for us to really establish sustainable solutions going into the future. In fact, just a couple of days ago, SAMHSA had released some new information about the original demonstration states being able to now add new sites within the state, which is something we have been advocating for since the beginning of the project in 2017. So very exciting future for CCBHC. So, Kacey, I'll turn it back over to you.
Thank you so much. So after the sort of, overview of CCBHC and the difference between CCBHC demonstration and expansion projects, now I want to talk about what did Oaks do with the CCBHC. Our process of implementation began with a vision for what this model and service could do to improve our ability to be effective as a service provider and really truly improve the health and well-being of the folks that we serve. So we started sort of at, in my mind, at the top of the funnel. We challenged ourselves to look past the intricacies and nuances of this CCBHC and the certification criteria, and first focus on understanding how this concept and model could fundamentally change how we function as an organization. This model was an opportunity for us to put into action all of the services and enhancements we believe improve the quality of care. And we had this opportunity because the CCBHC lessened the barriers and limitations of the fee-for-service and managed care contract-based service delivery that we once depended on. Once we had our shared vision, we moved to understanding our readiness for change as an organization, as well as our needs of those in our community. So next, organizational assessment. This step included taking a hard look at our strengths and our needs as an organization. So this included looking at operations, including our program functions, curriculum, staffing, human resources, quality, finance, facilities, and information technology, just to name a few. The knowledge of our strength helped us to understand how those skills could help elevate us to the next level. Mike will discuss in his continued portion of the presentation how we expanded our services based on our strengths in partnership with a commercial payer. On the flip side, the knowledge of what our agency's challenges were helped to inform areas that required additional support. For example, our agency needed additional training and sustainability to embed evidence-based practices into every aspect of our care, from admissions through treatment planning, through clinical supervision and discharge. As such, we partnered with a regional university for staff training and resources, which we still use and partner with today. In looking even deeper at our areas of need, some were addressed more immediately during implementation, while others evolved well past the initial implementation period. An example of this would be our decision to ultimately change electronic health record providers to NetSmart. We were having difficulties in our previous platform in easily tracking and reporting our CCBHC measures and data, which made it hard to utilize that data. The use of our project evaluator position, which is a required position within the CCBHC expansions, also evolved over time. We now use that position as a bridge between operations and quality, which has helped us to use data to inform program decisions and changes. So data is not just a checkbox to send to SAMHSA and the state. We are able to, with the use of our project evaluator, really use data, for example, to do a root cause analysis for how to better re-engage individuals who are lost to contact. Next, we engaged in a community assessment. So this step in the process allowed for our organization to figure out how to harness the power of integration in order to provide the most meaningful services possible. Of note, we have 4 different CCBHC expansion programs and 1 demonstration project. So we found the benefit in completing this step for all of our communities. Some were rural areas, some were inner city. So those were leading to different service needs. During this part of the process, we engaged various partner organizations, as well as community stakeholders, hospital partners, regional health hubs, FQHCs, and of course, the most important, those who receive our care and their loved ones. Then we're getting into the nuts and bolts. So that's like the bottom of the filter, or as Mike would joke, getting in the weeds of things. So this phase includes steps like developing job descriptions, recruiting and hiring for clinic positions, completing your cost reports, preparing facilities to obtain licenses that are required by the CCBHC, as well as potentially building out your electronic health system, your electronic health record to include reports so that you can capture and monitor quality data points. So as our visual on here shows, we need to treat CCBHC as the dynamic, living and growing model of care that it is. The steps are not linear, nor do they only occur once. So we should really see this as a continuous repetitive feedback loop, if you will. So next, Mike will expand our discussion by explaining how CCBHC and integrated systems of care that we've developed at Oaks informed our organizational growth and continued strategic planning.
All right, thank you, Kacey. Just get us on the right section here. Okay. So CCBHC showed us what we needed to do to prepare for the future of behavioral health and healthcare delivery. It laid the roadmap that we used to build our strategic plan to position ourselves to be able to implement and deliver integrated care. As an original demonstration site, CCBHC demo site, we began seeing the value in what we were doing as a CCBHC and sought ways to broaden the concepts and practices of this model throughout our agency. As a demo site, we were just doing CCBHC in one specific county in one area of the state that we covered. So it wasn't something we had initially rolled out organizationally. Our first opportunity to scale integrated care was by way of the CCBHC grants that I explained about a little bit earlier. These expansion grants were strategic in that they allowed Oaks and other providers to establish some foundation and footing in implementing this model in preparation for expansion of the original Medicaid demo project. Oaks took advantage of these e-grant opportunities. Since our initial demo began in 2017, we've been happy to have added CCBHC expansion services in 3 additional counties, as well as a 4th grant to support innovation and advancement in our initial demonstration site. These grants provided us with essential funding and a framework to build off of. As such, we developed strategic planning to utilize the expansion funding and find other opportunities to fully actualize integrated care at Oaks. So really, what are our gaps and what do we need to do to really be able to fully implement and bring forth this holistic model of treatment service? So the first for Oaks specifically was our addiction services. Oaks had primarily been a mental health provider of children and family services, residential provider, acute care services, but addictions was certainly one realm that we were a little bit lean in. So in looking at the CCBHC model and looking at the needs of our communities, we felt that this area was one that Oaks needed to really dedicate some resource and focus on growing and developing. So while we had some addiction services in the prior to CCBHC, the model really pushed us to implement a much broader continuum of addictions treatment services and fully step into that world as a provider. Through this CCBHC, we stood up outpatient and IOP addictions and co-occurring treatment services, along with ambulatory withdrawal management and medication assisted treatment, which also wove its way across our continuum into mental health primary treatment services. So not only did we stand up addictions treatment on its own, but we also were able to infuse the use of MAT into our mental health primary services as well. As we began our journey as an addictions treatment provider, we saw the tremendous value of including these services in our continuum and continued to build out our addictions infrastructure even to this day, adding new locations, adding new sites, expanding hours, adding new specialty. Understanding the power and efficacy of various forms of MAT, we found opportunities to obtain additional grant funding through SAMHSA and through our state for MAT expansion. And these grants help to complement our CCBHC expansion grants in our demo project in helping to stand up and broaden our use of MAT across multiple sites and levels of care. The next area that was a focus for us was around evidence-based practice initiatives. So as Kacey had mentioned earlier, use of EBPs is not something that was new or novel to us or our partners or other behavioral health organizations, but the CCBHC really demanded a much more robust use of evidence-based practices and use that really was consistent with fidelity of those models and interventions. So we recognized this and was able to prioritize this and partnering with our state as well as some local or state-based educational institutions such as Rutgers University to take advantage of different practice and training initiatives. So one of the training initiatives we took part in was an evidence-based practice initiative focusing on in-depth training and certification around cognitive therapy and motivational interviewing. So while CBT was offered to the clinicians, MI was brought in to include all levels of staffing. So not just focusing on those EBPs that are used by therapists and licensed folks, but really trying to infuse use of evidence-based practice throughout the diverse range of staffing that we employ. The most valuable part of that project, though, was not just the training piece, but was really the way that we leveraged that opportunity to develop a comprehensive sustainability and implementation plan that was developed concurrently, working with Oaks' executive team, along with the consultants that were helping to facilitate and conduct the trainings. The other part of the evidence-based practice initiative that we engaged in was specifically with Rutgers University, and this was focused very heavily on supported employment. And this was an initiative that really allowed us to implement and embrace the use of psych rehabilitation services and specifically supportive employment throughout our continuum of services. These are two initiatives that were not just one-offs. We actually continue with both of these projects through today. And actually, as we're talking now, we're kicking off, the rest of our team is on another meeting, kicking off the second round of our EDI initiative. The next part wanted to talk a little bit more through in terms of strategic planning was around primary care and hospital partnerships. While integrated care is a central theme and value of Oaks and our delivery of care, the CCBHC showed us the importance of developing a strong primary care partnership on hospital relationships. So we ended up working very closely with FQHCs as well as hospital partners in our communities to make sure that we had not just bi-directional referrals, but in one case in our demonstration project site, actually opened up a fully licensed ambulatory care space within one of our behavioral health facilities. So individuals coming to us for service or for partial day treatment can actually walk to another space within our facility and receive primary care treatment. We were very proud of that. It was actually one of the only, I think, licensed ambulatory primary care facility within another facility in the state. So that was quite ambitious and innovative in and of itself. One other project I'll highlight in terms of our partnership with healthcare was our Pledge to Connect project. Our Pledge project really focused on systems-wide intervention, looking at transitions of care from emergency departments and inpatient medical and psychiatric services back to the community. So this was a project that took several years to not just stand up, but also pilot. And it has shown some really great efficacy in showing the value of providing transitional support services to folks coming out of hospital settings and back into the community, not just helping them to initiate, engage with treatment, but also to address all those social determinant of health factors that prevent folks from remaining well and remaining in the community and avoiding that cycle back into the emergency department. One of the last pieces I want to talk about in terms of strategic planning was looking at technologies. Kacey mentioned as we began our journey, we looked at our electronic health record and we looked at different things and capabilities we would need to have to be an integrated care provider that can not just deliver care, but also collect data, report on data in a way that was meaningful to us, as well as reportable to entities like SAMHSA. And the CCBHC and integrated models of care really beg a much more robust and complicated method of data collection and reporting that most behavioral health providers were not accustomed to up until the CCBHC. So early in our demo, we worked to switch our electronic health record, and then also worked very closely with two of our regional health hubs, where we were able to make a close connection with them and their health information exchange platforms. So this project really allowed us to have what we call beacon alert reporting. So actually seeing our folks that are attributed to our treatment services who might be going into the hospital in real time, so we can make outreach to them and provide intervention and follow-up, as well as access to the health information exchange to be able to review records and health information for the folks that we're treating that might be also going to see their primary care doctor, or they might be going to the hospital or receiving some kind of specialty care. So this has been really critical in us helping to case manage and treat people while understanding the entirety of their needs, as well as being able to collaborate with these other physical health partners that are providing them with treatment as well. Lastly, I'll talk about the value-based repayment aspect of this. So we've talked a lot about CCBHC and that focusing on mostly the Medicaid and uninsured, as well as wrapping services around managed Medicaid and commercially insured folks with complex care needs. That our CCBHC helped us to leverage and implement an integrated model of care with a major commercial insurance provider. And the CCBHC gave us that foundation and that fundamental framework to be able to have that conversation and deliver on an integrated model of care, that we were able to pitch and actually develop a contract with a commercial insurance partner. So the value-based repayment relationship, I'm going to explain that a little bit further in a couple slides here, was really part of our big picture of how do we expand this service and to other payers, so that when folks walk in the door, integrated care is what they get, regardless of who their payer is and where they're referred from, and that this is Oaks' ability to be able to do this kind of work regardless of payer. So just talking a little bit quickly, moving into the administrative and fiscal side of the house. So part of delivering integrated systems of care, as you can see, requires a pretty broad continuum of different kinds of services that typically in a fee-for-service or managed care kind of environment are not otherwise billable or reimbursable. And integrated care really does beg the kind of flexibility to meet the needs, the complex needs of the folks that we're working with. So as such, CCBHC and other integrated care models have really used alternative payment methodologies to be able to deliver these kinds of services in the way that we need to be able to deliver them to address the holistic needs of the folks that we're serving. So alternative payment methodologies need to be formed, like I said, in order to fund the unique and broad array of services of CCBHC. And these things include just general care management, nursing care management, peer support services, coordination of care with other physical health providers, to really make sure we're capturing the cost of delivering services that are not traditionally reimbursable. So specific to CCBHC, I think this really did introduce a very unique way for behavioral health providers to be reimbursed for services. The CCBHC alternative payment model really did serve as a template for similar integrated care models, including Oaks' integrated care program that we partner with a commercial insurance provider for. As many of us are familiar with the limitations of fee-for-service, the CCBHC alternative payment methodology really is one that incentivizes the delivery of quality care, as well as improved outcomes of care, using rates that are based on the actual cost of a provider to deliver those services, along with bonus payments that are based on standard healthcare measures that look at the treatment of the whole person. Using this system, providers are afforded the opportunity to think outside of the box in terms of creativity and flexibility, and delivering services while we know that we're being reimbursed in a way that truly covers the cost of doing business. So I'm going to break that down a little bit more. Whoops. So kind of breaking down the different components of the alternative payment methodology, you can see that there are three generally distinct different types of ways that CCBHCs are paid, and three different kinds of ways that we might want to leverage what we do with other payer partners in terms of being able to get reimbursed to deliver the type and quality of care that we know is necessary to help folks get well. So the first we'll talk about is the bundled case rate. So different than fee-for-service rates, that are billed and reimbursed per encounter. The bundled case rate, at least in New Jersey, we use a prospective PPS2 rate, which is a monthly reimbursement rate that varies across different levels of intensity and different diagnostic areas. And these are based on the types of services provided, as well as the overall number of services provided in a given month. The bundled rates, as I mentioned, are stratified by diagnostic categories, and the rates themselves are derived from different factors, most of which is broken out in a cost report that is developed to derive these monthly rates. Other CCBHCs do a per diem or per day rate. New Jersey and Oklahoma elected to do the PPS2 monthly rate. Again, this allows for the established rates to cover the difference in the overall cost of care that is needed to provide comprehensive integrated care for folks with complex care needs. Using this system, providers are afforded the opportunity to be creative, and given that the bundled case rate covers the cost of delivering these different types of services, we can think beyond what's traditionally billable and incorporate services that I had mentioned previously that are traditionally not billable, that we know really make a difference in terms of helping people to get well and remain well. Since we are incorporating the various different kinds of services, one of the things that we also are able to do is still submit claims, these typically or traditionally non-billable claims, as shadow claims. And this is really to show all of the effort and all the services actually being delivered to get a picture of the total cost of care being delivered to an individual in a day, month, week, or year. The second piece is measurement-based care. So in addition to the bundled case rate, CCBHC employs the use of measurement-based care that establishes a value-based partnership and pay for performance. This concept is key in how the model's payment structure reinforces the delivery of quality care and puts the client at the center of services. The measurements used in CCBHC demo project are HEDIS measures that are endorsed by the NCQA and are used as standards in healthcare throughout the country, as well as CMS. The measures included are based on claims data, and some are based on EHR data, but the ones for value-based repayment are based on claims data, and allow us to capture outcomes and performance-based information from throughout the system, not just with the behavioral health provider. So examples of this are follow-up after ED or hospital discharge within 7 to 30 days. These measures are specifically direct providers to target gaps in the system of care between hospitals to ensure that individuals we serve are not lost during this critical transition. So as we know, individuals who successfully re-engage or engage with providers in these timeframes have improved outcomes of care and a decreased likelihood of recidivism with the hospital. So to draw a connection back to the bundled case rate, this measure really highlights how the ability to provide a diverse range of services under a bundled case rate allows providers to close these kinds of system gaps and enhance outcomes of care while helping to correct the gaps in our systems. And lastly, flexibility. I've really mentioned that a lot. So the reason this payment methodology is so critical is because it really fundamentally changes the way that we can survive, thrive, and best serve our communities. Beyond this payment model allowing for sustainability, it really influences providers to be dynamic and creative. And it does this because of that prospective payment system and because we're being able to be reimbursed for services that are traditionally not billable, while also getting credit for those things by submitting them as shadow claims to our payer. And so overall, this innovative payment model and this alternative payment model is one that really does allow us to thrive and is very much a fundamental and a key piece of how CCBHCs and our integrated care contracts with commercial providers allow us to be successful. So a little bit about the future of CCBHC and integrated care. So obviously sustainability is a big area of focus. So beginning with the handful of planning grants that were given to states about 6 to 7 years ago, to the hundreds of CCBHCs that exist now throughout the country, CCBHC has truly grown to become the model of care that will catapult behavioral health into the future and bring behavioral health and community-based care to the proverbial table with other physical healthcare providers. The CCBHC elevates behavioral health and community-based work and allows us to demonstrate its importance and relevance to overall health and wellness. Over the past 6 to 7 years since the CCBHC has begun, we've found footing in long-term sustainability due to the efficacy of the model and the excellent individual and population level outcomes it has yielded. While the model began with a handful of demo projects throughout the country, it's certainly blossomed with expansion grants, and we now see a sustainable future via the federal expansion of the demos, as well as states implementing their own state plan amendments and 1115 waivers to sustain, and in some cases, introduce these models in states that were not originally demonstration sites. Beyond the federal and state level sustainability, it's clear that integrated care and CCBHC have a place in healthcare broadly and not just with the Medicaid population. And so while CCBHC serve a diverse payer mix, coming to the table with our commercial partners is another key step for providers to take in broadening their ability to deliver and be reimbursed for the delivery of integrated care. Most CCBHCs who serve commercially insured clients now are able to bill fee-for-service rates for services under their commercial contracts, but are not reimbursed for other aspects of care delivery and may likely not have any sort of value-based reimbursement incentive. So in terms of developing a commercial partnership, as part of our strategy and our commitment to broadening and deepening our work in integrated care, Oaks began the process of developing a contract with a commercial insurance partner after the beginning of our CCBHC. So the relationship and discussions with this specific partner began about 2 years prior to the implementation of the program and about a year into our CCBHC demo project. The foundation for this was born out of a few different factors. So first and foremost, the CCBHCs had been gaining attention throughout the country for the new concept and system of care, as well as its ability in delivering promising outcomes. And so CCBHCs were very much being seen as the future, and our commercial insurance partners were taking notice. And our commercial insurance partners, while taking notice, also were prioritizing integrated care and were shifting into thinking about the delivery of integrated care and seeing the value of supporting delivery of behavioral health services and addressing the social determinants of health as a way to improve overall health and wellness and actually to reduce total cost of care. So given the size and scope of New Jersey CCBHCs involved in our commercial partnership, our commercial partner had established relationship with organizational leaders and thought it wise to partner with us as subject matter experts in this area to help develop their model and inform what this partnership and contract might look like. So in terms of developing the model, it began with the CCBHC framework, but really was tweaked and tailored to the specific challenges this commercial partner saw in the community in which they were present and the challenges that their members specifically presented with or demonstrated. So following a series of learning sessions and work groups with New Jersey CCBHC leadership, along with consultants from around the country, the model was born. Beginning with a single pilot, the model was eventually tweaked and fine-tuned before it was scaled and ultimately made its way into its mostly final form. And I say mostly because while many of the main concepts and expectations remain the same, many of the details and challenges identified have been developed and adapted and refined over time as we've really gotten the project off the ground. So it's been a dynamic project and partnership for sure. So once negotiated, the project began its implementation with considerable training by our partner on the details of data collection, billing, patient attribution, et cetera, as well as operational, technological changes that organizations had to make in order to adapt to delivering on this new contract. So a lot of it was built off of our CCBHC work, but there were obviously some specifics and some specific differences related to this commercial partnership. Changes were made to our staffing, our EHR, and billing, just to name a few. Similar to the CCBHC, this partnership included this new payment methodology, as well as service delivery and outcome expectations. While the reimbursement methodology and payment methodology were not identical, they were very much consistent and similar, and really drew on the same sort of bundled payment, value-based repayment kinds of principles and concepts. So delivering the services, as we stood the project up and our partner committed to scaling this geographically, we continue to have structured meetings and work groups to ensure the delivery of the project was meeting its targets and that roadblocks or challenges were discussed and resolved, and that we were really tweaking and changing the model to best meet the needs of the community, the partners, and certainly the folks that were receiving the service. The partnership is still quite dynamic, and unlike what one might expect, it's very much collaborative. Some of the challenges we faced early on were around our billing process, having to retrofit our EHR, but all things that we anticipated and worked through, especially over that first year. And then despite the newness of the project, it's already showing consistent outcomes as the CCBHC has nationally. To date, the project has shown a marked decrease in utilization of ED visits, inpatient admissions, and readmissions for those serviced by the program, as well as an overall reduction in total cost of medical care that largely offsets the increase in behavioral health expense. So essentially what they're seeing is for the folks involved with our integrated system of care project, that compared to the general population of this commercial payer, they're less frequently being hospitalized, they're less frequently being rehospitalized, and they are actually reducing their overall cost of care, even though we're seeing an increase in the cost of behavioral health. And additionally, those served demonstrated improvements in functioning across multiple life domains and social determinants of health at a higher rate than those not served by the program. So we're seeing, the benefit on the payer side, but most importantly, we're really seeing the people involved in this system, like CCBHC, really doing overall much better than folks not getting this comprehensive, delivery of service. All right, so we're going to kick it back off to Kacey, and she's just going to wrap us up with some key takeaways before we do some questions. So, Kacey.
Thank you. So first one, knowing your program and your readiness for organizational change. Key takeaway here. Where are you strong and where are your weaknesses? And then on top of that, what are your selling points? And how can you leverage that to then develop commercial partnerships or other programs, as Mike just discussed? Second, using the CCBHC as a roadmap for your strategic planning. See the CCBHC model as the future of healthcare delivery and use it as a template to identify other areas of growth within your agency. For example, we see that MAT is an important part of the addictions continuum in the clinic. What about putting that in your agency's strategic plan to stand up your MAT services within your outpatient mental health programs as well? Third, relationship with partners. Who are your partners in your community? Who complements what you do versus who are your competitors? And then with the competitors, how can you develop collaborative efforts with them to meet the needs in your community? Maybe you can refer to a partial hospital program for clients who need a higher level of care, and you can be utilized as a outpatient or IOP step down for individuals who are stabilized. Fourth, advocating as a provider group. So this is a crucial piece in our minds. Identify other CCBHC providers or other integrated care agencies that can help you advocate for overall projects and goals with SAMHSA or the state or your county. We have found there is strength in numbers when advocating with grantors or payers if there are growths or needs in your program. Next, working with your state to identify a sustainability plan early. This is especially important if you have a program like CCBHC Expansion, which is a fully grant-funded program. And then finally, the model grows and evolves over time. I know I said that several times throughout this presentation. This is not a once and done implementation process. Our program from 6 years ago, which was the CCBHC demo, versus 2 years ago, our initial CCBHC expansion project, versus now, where we have 4 CCBHC expansion projects, all look different because of lessons learned and not being rigid or complacent. So use that project evaluator for data to inform organizational decisions, complete or redo that community assessment when you need to, all to the end of ebbing and flowing within your programs. So thank you guys so much. Mike and I will turn it back over to you, Corey.
Thanks, Kacey and Mike, and I apologize. I am having some hardware difficulties. As long as you can hear me, I have a couple questions to round out our hour. You know, the first one is you guys talked about the importance of your payer relationships, you know, the commercial partner relationships, as you called them. And we often hear that CCBHC status is important for the future of community mental health, mostly because of a more substantial relationship with payers, and then also the ability to expand and scale. Speak a little bit more about, you know, how executives at provider organizations can use this status to improve those relationships, and how they can use this to, you know, grow their business model sustainably.
Yeah, it's a great question. So I'll give an example of this. With the commercial partner that we had worked with, I think what we found is, and it sort of aligned at a really great time in terms of what they were looking at strategically and what our capabilities were becoming and what we were developing. So we were really able to hone in on what are the actual differences we're able to make in the folks that we're serving's lives, and how does that speak to the strategic plan and the pain points for our commercial partners and the communities that they're, you know, that they mostly represent. So that really was the impetus for a lot of that initial conversation in terms of, you know, what are the needs that they see, what are we able to do, knowing what we were able to do and knowing our value in terms of what we can bring to the table that really addresses their pain points and issues and challenges. So I think that's really key. Another example I'll give too is, and this is sort of outside of the box of commercial insurance relationships, but in New Jersey, our Medicaid division had established a quality improvement project with some of our hospital partners. And that quality improvement project was, as again, another value-based repayment project, really targeting, mostly targeting behavioral health outcomes and measures using the same HEDIS measures that we were using in our commercial partnership and the same HEDIS measures or similar HEDIS measures that we were using for CCBHC. So we were able to, you know, align with our hospital partners in a way where we were both speaking the same language, and at the same time we're both had the same financial and clinical outcome goals and targets, and it kind of brought us together in a way where we were both able to collaborate and support each other to thrive. And so it was really the landscape of, I think, what was happening out there and knowing what our strengths were and how to put those things forward and really leverage that with partners, whether it's commercial insurance partners, hospital partners, and so on.
And another piece as well, we were able to collect data from our years of CCBHC prior to engaging in our commercial partnership. We were able to experience success in reduction in individuals going to the emergency departments for traditional outpatient medical services, reduce the number of individuals going to inpatient psychiatric and addictions level services. And those are not, we feel that we were able to do that with the extra services offered in the CCBHC continuum: nursing services, peer services, case management. Those are not traditionally reimbursed services in commercial insurance. So by showing the benefit of this additional support within the continuum, I also think that that was an important data piece that we were able to show our commercial partnerships.
Thanks, guys. Actually, Kacey, along the lines of developing new services, you know, this approach is seen as a way to develop new competencies, new service enhancements, and obviously that's what you guys did. Were there any big challenges to that other executives should be aware of? You know, how do you approach, you know, an idea and say this is going to work versus this is not going to work?
Yeah, so that's so loaded. I'll use the MAT thing as an example of that, because in terms of readiness for change and developing new competency, MAT was kind of unique in that it presented not just some logistical and practical challenges for us in terms of finding data waived prescribers to really bolster what we were able to do with respect to MAT, but also philosophically and ideologically, where do we stand as an organization in terms of medication assisted treatment, and was our philosophy of care consistent with MAT best practices? And so, that I think was a good example of, we see that there's this best practice out there. We see that there's an area where we need to develop and grow. for our community, but there's sort of these underlying challenges that as you start to say, oh, this would be fantastic, you start to realize the practical and ideological kind of barriers around that. So it really did take a lot of training and education and support. And then obviously on the practical end, being able to, recruit the right staff, but also in recruiting those folks, making sure that they understood our philosophy in terms of treating the whole person, and avoiding folks and providers that might come on that were otherwise resistant to doing MAT or, had philosophies or beliefs that were not consistent with best practice in the way that Oaks, operated. And then also with addictions in general, we were very strategic in terms of building and drawing on our experience and expertise. So, what we were able to bring to the table generally in the addictions world was a really strong emphasis on co-occurring treatment. As a mental health provider, we were very much expert in how to treat, handle, manage, case manage folks with mental health needs. And what we saw in a lot of our, a lot of the addictions treatment provider landscape was that was somewhat lacking, and folks very much were dug into the drug and alcohol aspect of treatment and didn't have the complex infrastructure to really make sure that we're addressing, the mental health side of the house. So that was, I think, a strength that we were able to bring with us as we expanded, addictions treatment services at Oaks.
And to go one step further in terms of, I mentioned earlier in our presentation, my excitement and passion in welcoming our peer recovery specialists into our workforce. This was, I feel, a missing link in mental health services prior to our clinic models. And we have been able to welcome that level of staff now and embed them into our care management programs, embed them into our clinical services. They can facilitate recovery groups. But with that, it is a very different level of demographic in our staff, right? We learned that they really need different levels of support, different levels of understanding the ethical components of their job. What's healthy self-disclosure versus what could be harmful for a client. Understanding their own personal countertransference towards a client. They have a particularly difficult client and they see themselves in them or a family member. They don't necessarily have or had the skills to be able to cope with that. So I think one of the things that we've really had to pay attention to is how do you supervise, train, and ongoing support your peer staff that you're going to bring into your continuum.
That's great, Michael, Kacey, that's great. We have about 3 minutes, so I want to give you both a chance here at the end to impart your parting wisdom on what we see in Open Minds is definitely one of the future models of behavioral health care and integrated care. Michael, if you'd like to start, just let us know what you think we should know going out the door.
Yeah, just I think knowing yourself, your organizational readiness for change, and understanding that those opportunities for CCBHC expansion and integrated care opportunities are coming up. So be on the lookout for those, but go into those, I think, fully aware of what you might need to do and are you ready to make those changes. And for others who might not be ready to be a CCBHC provider themselves, really aligning yourself with other CCBHC providers in your communities. Because one thing about the CCBHC and integrated care is that it is very much a hub and spoke model. And so partners like Oaks and like others that are CCBHCs look for providers that have niche and specialty kinds of services. And so if you fit that bill, work with your partners, work with your local CCBHCs and integrated care providers to really see how you can complement what it is they do and be part of that bigger system.
And, from my end, I would say, look at your quality departments. The incorporation of project evaluators in our integrated care models has been an absolute game changer for us. There are so many different data points that we want to look at as an agency that we need to report on for SAMHSA and the state of New Jersey. And we have been able to utilize that project evaluator position in a way where data is now able to be molded and understood and has why we're different from 6 years ago has informed the curriculum we're using at our programs, the way we're training our staff, the way we're using our electronic health record.
Michael, Kacey, thank you one more time, and I want to thank everybody in the audience who joined us today. I want to remind everyone that the slides and recording will soon be available on the Open Minds website. The full Circle Elite Executive Roundtable series is also available on demand as part of the extensive Open Minds library. It's also available on the Open Minds YouTube channel. And finally, if you would join us for our next roundtable, that'll be Thursday, March 16th at 1 p.m. Easterns. It'll be strategies for strengthening financial sustainability, the Little Friends approach. For a full list of upcoming roundtables or to register for that event, visit the Executive Roundtables page under the events tab at www.openminds.com. Thanks, guys, and I hope everybody has a wonderful afternoon.
Thank you, Corey. Be well, everybody.
Thank you all.